Good afternoon, ladies and gentlemen. My name is Michael Whitehouse, and I'm from the University of Bristol. I'm going to talk to you about risk factors and outcomes of treatment for prosthetic joint infection in hip replacement and in knee replacement. So when we look at risk factors for prosthetic joint infection, we started off with a piece of evidence synthesis looking at how many cases there were published in the world literature. And in summary, it came to about just over 500,000 for hips and knees together. So we can see here part of the value and the strength of the NGR has linked data, where we were able to obtain over 600,000 records of primary total hip replacement with over 2,700 revisions of PJI. Now, PJI is a relatively rare event, fortunately, but these numbers give us the power to start to really explore risk factors. You can see here the patient characteristics, surgical factors, and health system factors we're able to explore. And by linking in the HES data, we could also bring in ethnicity and comorbidities in the 5 years before primary. So with the analysis for both hips and knees here, we used an overall effect using Poisson multi-level model, counting for clustering at the hospital level. And this is typically what other papers have done in the past, just looking at those overall effects. However, we thought that time-specific effects, that is breaking down the follow-up period into smaller chunks of time, could be important, because obviously there are acute and chronic infections and differences in terms of infection that develops following operation compared to that from hematogenous spread later. All models were adjusted for age, sex, ASA, and BMI. So we could see here that male gender was a risk factor. This is commonly known from other previous studies, but we also found in hips that increasing age led to an association with a lower risk of revision for PJI, BMI increased risk. I've highlighted dementia and liver disease here because these highlight the value of the time period specific effects. You can see here in dementia, the effect is in the first 3 months, whereas in liver disease, it's actually later from 2 years onwards. Other factors, COPD, diabetes, etc., common with other previous studies, and we can see the sizes of the effects here. Interestingly, we found that fractured neck of femur was associated with an increased risk of revision for PJI. Osteoarthritis was lower risk. Surgical approach appeared to be associated too, with posterior approach having lower risk of revision than lateral surgical approach or other surgical approaches compared to here. Fixation and bearing surface appear to be important as well, with ceramic containing bearings having lower risk of revision for prosthetic joint infection. We can see here in the fractured neck of femur, again, the effect was early in the first 3 months following surgery, whereas in the approaches, lateral versus posterior, the increased risk in the lateral group was from 3 months onwards and then persisted with time. So with the hips, similar to previous findings, we found increased risk in males, high BMI, diabetes, rheumatoid arthritis, COPD, and non-ceramic bearings, contrasting with previous findings, increased risk in younger patients and liver disease. New findings were of increased risk with dementia and fractured neck of femur in the short term and the lateral approach in longer term, but no association with surgeon grade or volume. To contrast that to knees, we had slightly more knees, 679,000 with just under 3,700 episodes of revision for PJI. Similar to previous findings, again, you can see and contrast that with our findings in hips. The new findings in knees were increased risk in peripheral vascular disease and a decreased association with risk of revision PGI and uncemented total knees, unicompartmental knee replacement, including unicondylar and PAP FEMS, and cemented total knee replacement, and also higher risk of revision in posterior stabilized fixed bearings and constrained condylar compared to cruciate retaining, and a lower risk in unicondylar knee replacement. We did find here that there was a higher risk of revision for PGI in high volume centers, specifically in that earlier time period, which maybe represent aggressive treatment of knees in those more specialized higher volume centers. When we went to look at outcomes of treatment, we felt the current evidence was limited by a lack of RCTs, limited outcomes considered, small cohorts reported generally from centres with selective methods of treatment, and also a limited number of outcomes considered in terms of what could happen to these patients following surgery. And this is important because the volume of work we do for prosthetic joint infection continues to increase, and there's been uptake in the use of single stage surgery, more so in hips and in knees, and these are the figures for hips. So for the outcomes of treatment, we're able to obtain just over 500 single-stage revisions in hip and just under 2,000 two-stage revisions for PJI in the hip. And we can see here the outcomes of interest we looked at in the study, all-cause re-revision for PJI and mortality with the numbers in each group as listed there. For knees, as you'd expect, a higher proportion of two-stage revisions, just over 2,300 with just under 500 single stages. Again, similar outcomes, and you can see the numbers in each group there. So when we performed this analysis, models were adjusted for age, sex, and ASA. We looked at the overall hazard ratios at 2 and 4 years using Cox shared frailty models. And again, we broke down into those time-dependent hazard ratios. And we used Poisson regression with baseline hazard rates and restricted cubic splines to model this. And we also looked at the number of revision procedures that patients underwent. So what did we see? In the hips, we could see that it appeared that the re-revision for all causes and re-revision for PGO might be higher in the single stage group, and mortality looked fairly similar. We can see when we look at all cause re-revision that the hazard ratio of revision at 3 months was higher in the single stage group than the two-stage group, and this waned with time. Similar to what we saw in re-revision for prosthetic joint infection, you can see here the figures at 6 months indicate that significant effect has waned at that stage. When we looked at mortality, we can see similar rates over time between the single stage and two-stage groups. When we looked at the number of revision procedures that patients underwent, we could see that the mean was 1.3 for those that were initially treated with a single stage, compared to 2.2 in those treated with a two-stage. Moving on to knees, we could see that, again, the rates were a little bit different, but this time slightly closer together. And we could see that all-cause re-revision rates, actually, there was no significant difference in the single stage and two-stage groups. And again, re-revision for PJI, no significant difference. Mortality was a little bit more variable here, but overall, no effect seen at 2 years or 4 years for the difference in the risk of mortality. We could see that the number of revision procedures were 1.2 in the single stage group and 2.2 in the two-stage group. So in conclusion, for the outcomes, we could see that patients revised with a single stage revision for PGI undergo fewer operations in both the hip and knee group. This might be an important factor for patients when they're considering the treatment pathway they prefer. In the hip, the risk of unplanned further revision surgery for all cause in PJI is higher in the single stage group, even though they undergo less revisions, but that is not the case in knees. The rates of mortality between the groups are similar, indicating that both should be considered to be of equal safety when mortality is the outcome of interest. If any of you would like further information on the risk factors work, then these are the two references in Lancet's Infectious Diseases. Lots of information contained there, and we hope to join those with some papers on the outcome section quite soon. Thank you very much for your attention.